I want to just tell you what a great guy Mike Hare is and how helpful he has been to us. Mike has been the head of and continues to be the lead on our education committee. He was the lead on our scientific session for 2 years. Mike was head of the education committee when we revised every single brochure that MGFA had, and Mike, along with Yu-Bing Lee and the others, a remarkable team of volunteers, made sure every single one got reviewed by an expert to make sure that the information that we're giving is the most timely, and Mike really helps with that. They also, the Education Committee, took on the project of emergency medicine management, because we all know, we were hearing from so many people about less than ideal experiences in emergency rooms, especially when they were in a situation with impending crisis, but even when they went in for other things that, you know, that's, again, that first thing where you hear is, can you spell that? So he and Amanda Guidon were our speakers for our emergency management of MG video, training video for emergency personnel, EMTs, and those that work in emergency rooms. So he is an amazing volunteer. He also, along with Ricardo Rhoda and Shruti Raja, is one of our postdoctoral fellows who did a fascinating project as the MG community.
Thank you so much. That was way too kind. It's a pleasure to be here. Thank you for having me. Hopefully I'm going to be able to give you some important information. I might be going over things you already know today, but I think I've left enough time in the talks I can leave some time for questions. I hope everybody had a nice time at the baseball game last night. That looked really fun. So today I've been tasked with giving a talk about crisis and emergency management of patients who are having a lot of weakness from myasthenia, and this kind of grew out of the project that we were doing with the education committee. I'm going to try my best not to scare anybody, but we are going to be talking about probably the worst manifestations of myasthenia today. Just a few disclosures. Thank you for supporting my research. A lot of the people in this room probably just did a survey for me a couple months back, and you're going to see that in press soon. I serve on some of the advisory boards for the folks outside, and I really just want to say thank you to Amanda Guidon at MGH. She helped with a lot of these slides and couldn't be here this week. I just want to say thank you to her. So we're going to talk very briefly about how to classify myasthenia. You've heard a lot about that this week, I'm sure. I'm going to talk a little bit about how do we define crisis, what is impending crisis, what are some of the things that might trigger that, how do we as clinicians think about evaluating patients who come in who are having a lot of weakness with myasthenia. What certain tests should you expect if you would unfortunately find yourself in that type of a situation? What are the treatments that might be proposed for somebody, and how is it all going to come out? What is the prognosis? So there's lots of different ways to classify myasthenia gravis. So myasthenia is an autoimmune disease, as you've all heard, of the neuromuscular junction, and it causes fatigable weakness in lots of different muscle groups. And like many of the conditions that neurologists see, there's this concept of selective vulnerability. The nervous system isn't affected the same in each condition. And although myasthenia is sort of this generalized disease, it really sort of picks off certain muscle groups more than others. And the one that we're most concerned with today is the muscles of breathing function. There's probably about 70 to 100,000, maybe a little bit more, folks with myasthenia in the United States. And it affects men and women equally. There's lots of different ways that people will think about classifying myasthenia. So you can think about where is the weakness? Is it weakness in eye muscles and eyelid muscles, or is it weakness in limb muscles? Is the condition responding to the treatments that are proposed for folks? Is there pathology in the thymus gland? How old are folks that they're getting it? And then increasingly, we're thinking about the condition in terms of the antibodies that we can measure in blood. So there's acetylcholine antibodies, there's MuSK antibodies, and increasingly LRP4 is sort of emerging as an antibody to measure. And I always think it's important going in to sort of think about what are the goals. When I go in to see a patient and I'm talking to them about what we can expect going forward, I think of my goal and our unified goal of trying to achieve a point where a patient is having very little symptoms or no symptoms at all, with very little side effects. And that's where my research is right now, is I'm thinking about how do we quiet down side effects but still have good outcomes for people. But this is sort of what I keep in the back of my mind, even when people come in very sick to the hospital. So what is the prognosis for myasthenia? Fortunately, for many people, it's very good. One of the things, pointer here. Yes. So one of the things that we know from population research is this is the percent of people over here, and this is time on the bottom, and this is how long it takes to have your most severe symptoms from myasthenia. And you can see that the overwhelming majority of people will have that within the first 2 years that they're showing symptoms of myasthenia. Most patients begin with ocular weakness, so either with double vision or eyelid ptosis. A large proportion of patients will have weakness outside the eyes and eyelid muscles within 2 to 3 years. And about 20%, like a quarter, can have myasthenia crisis or impending crisis. Often it happens after the first year. If you have acetylcholine receptor antibodies, if you have MuSK antibodies, it tends to happen more rapidly, and in many patients that can be the presenting thing who have MuSK antibodies. So this is a really nice slide from a number of years back, and basically it sort of outlines how people are doing nowadays who have myasthenia. So this is percent mortality. So these are people who die from myasthenia. And as you can see, at the turn of the 19th century, it was almost everybody. Now we're sort of down here, like 0 to 5%, which is great. And you can see some of the things that led to that. So here's where we started to have better ICU care and ventilatory care. And then here's where a lot of the immune system medicines started. So ACTH was sort of the first version of steroids, and then we had prednisone and other steroids. Here's where the first use of plasma exchange was in 1975, and now we've got lots more therapies. But it's just a good idea to keep this in mind as well. And I remind my non-neurologist colleagues who take care of patients who are having myasthenia crisis that we expect a good outcome because ICU physicians often see people who are very sick and often don't make it. But I always remind them that we expect a good outcome and to please keep that in mind. So what is crisis? What is impending crisis? So I thought I would start with sort of a clinical example. So this is an example case of a 28-year-old school teacher who has anti-MuSK myasthenia and has a history of previous breathing trouble related to the myasthenia and has been in the emergency room before and comes to the emergency room now with new shortness of breath. She's being treated with a combination of rituximab and prednisone, and recently under the care of her team, has been sort of bringing down the dose of her prednisone over time, but unfortunately she got a fever for 3 days. Somebody gave her azithromycin, which is a Z-Pak, and suddenly developing shortness of breath for several hours and was having some trouble with swallowing and trouble with neck weakness. So she comes to the emergency room. She seems really anxious, as anybody would be if they're having trouble breathing. She's able to speak in full sentences, but she is having some slurred speech. Eyelids are drooping a little bit. She has difficulty holding her head up, so her head is sort of dropping forward, which is actually a unique thing to musk myasthenia, that the neck extensor muscles are affected more than the flexors. She doesn't want to lie flat on the bed because that makes her feel much, much worse. And she has a lot of weakness. So this school teacher, this woman, is experiencing what would be classified as an impending myasthenia gravis crisis. And what is that? So that is severe weakness of muscles due to myasthenia that could lead to crisis in the short term. So like days to weeks. Sorry for my misspelling there. And what is myasthenic crisis? So that is where the breathing muscles become so weak that you need some support of your breathing with either a mask to help push air in, or to have a frank intubation, which is where you're on the breathing machine in the ICU. And our job, I was thinking about this as I was walking over. I was like, well, what slide would I add that I don't have? And I kind of think of it like as a highway, and you're kind of going along this highway, and you're heading towards crisis. And our job is to kind of try and get you off the highway, for you to sort of take an exit so that the impending crisis does not become a crisis. And that's why it's so important, where if you're feeling any of these symptoms, to get in touch with your doctor right away. One thing that always comes up, and people always ask about this, are what are the triggers? Like, why would this happen? Why would this happen to somebody? This is this school teacher was doing really well, and then all of a sudden she's having trouble with her breathing. So what are some triggers? So there's some really nice studies. These are some of the big ones. So we think about illness, and remember the example, patient had a fever and an upper respiratory infection, so she had number 1 and 2. Sometimes a surgery can cause trouble, and surgeries are sort of big stimuli to the immune system. You're sort of cutting into the body, and it sort of ramps everything up. It might be because the medicine that you are taking for myasthenia is being reduced over time, and that results in more weakness. And it could be that you're exposed to a medicine that maybe is on the list of things that may cause some trouble with myasthenia, and I'm going to show you that in a second. It could be a pregnancy, it could be stress, it could be heat. In many people, there's no identified trigger. So there's 3 series of patients that were written about that I think are really important, and I've sort of highlighted in orange the things that came up most frequently. One series had 91 patients who had a myasthenic crisis. Another had 73, and another had 63. And you can see that in the first 2 series, infection was a big one, particularly upper respiratory infections, pneumonia, or a nonspecific upper respiratory infection. Flu is a big one, having just gotten out of flu season. In the 3rd series, surgery tended to be an issue for folks. Another one to highlight, not in the first 2 series, but in the 3rd one, under treatment was an issue. And in many people, it's just unknown. Under treatment's a big one. I just reviewed a paper, and that was one that came up often in this series that'll be published later this year, I think. So a big question that I always get from my patients, and I'm sure many of you ask your physicians, is what is this list of medications to avoid? And it's really hard to study this, and it's really hard to know if these are hard and fast things. Is it every time somebody takes one of the medicines on this list, are they going to have trouble with myasthenia? And the answer to that is overwhelmingly no. Many people take these things and do just fine. But there are people that take these things and don't do just fine. And it's more than one would expect to be by chance. But it's really hard to study this. So a lot of this comes from sort of anecdotal evidence or reporting the results of sort of populations that we see in our clinic and trying to associate when people do worse, were they exposed to one of these drugs within a couple of weeks. As Nancy just said, we were going through this with the education committee over the last 2 years and sort of looking at all the evidence. And the list on the MGFA website is probably the most up-to-date and evidence-based list that's available, in my opinion. But some of the things on the list, so beta blockers are a big one. That's a blood pressure pill that many people in the United States take. Calcium channel blockers are also used to treat blood pressure. Some of the antibiotics, so Cipro or ciprofloxacin is a big one that gets prescribed a lot for urinary tract infections. Its cousins, levofloxacin and moxifloxacin, often get used for community-acquired pneumonias. Aminoglycosides, you're less likely to get or be prescribed one of those outside of a hospitalized setting because those are IV medicines. And then a big one is this one, azithromycin. That was in the example case. So that's the Z-Pak that people just give those out because they're so easy to give, but they can be big trouble. Some of the agents that are used for anesthesia. So sometimes when people are undergoing a surgery, they'll get a medicine that blocks the neuromuscular junction. And as you might imagine, that's probably not a great plan if you have a problem with your neuromuscular junction from myasthenia. So it's always important to tell any anesthesiologist that you have myasthenia so that they know to adjust the medicines. And then a big one that has come up over the last couple of years are a class of medicines called the immune system checkpoint inhibitors. They're an amazing treatment for cancer. And the way that they work is that they sort of turn on the immune system to fight off a cancer. And it's amazing how well these medicines induce the body to get rid of a tumor. However, they can be a big problem for somebody who has an autoimmune condition because you're turning on the immune system. And people can get quite sick with these. And some people can get myasthenia just because they got one of those drugs. That's a well-described phenomenon that we're seeing increasingly. And there's a big statement about the checkpoint inhibitors if you want to read more about that on the website. But they're very commonly being prescribed for all different types of cancers now. And I think a great resource, I'm biased because I've been working on it, but is the MGFA website, and there's lots of information on there about this stuff. So if you go to the website, at the top there's a section called Living with MG, and there's a section, Drugs That May Worsen MG, and if you click in there you can get lots of information. I always push this too. I don't know if any of you have that on your phone or smart device, but there's an app called MyMG. I don't know if the list on here is as up to date as the list on here. Nancy can comment. There you go, same list.
In fact, the whole app doesn't look like that anymore. It's been rebranded, and it exactly matches the list on the website.
I need a new picture. But it's great. So I tell my patients to get this because you can just like push a button and like hand your phone to the emergency room physician or physician's assistant or whoever happens to be there that day and say, try not to give me one of these medicines if you can. Treat me with something else. You come in with a urinary tract infection or something like that. It's a great way for you to advocate for yourself because honestly, so myasthenia is a rare disease, as you all know, and even in major medical centers, you may encounter physicians who really don't know a lot about this condition. You need to advocate for yourself. And this is a great way to do that. The other way that I always encourage people to advocate for yourselves is to just say, you know what, you should page my doctor, or you should page the team of neurologists that cover for my doctor to talk about this treatment plan. And I never mind when I get phone calls from the emergency room. I got one. I was so surprised the other day because it was a physician that I know well that like never asks for help. And he called and he's like, I don't know a lot about myasthenia. What can I do safely? And I was like, yes, it's working. I was like, thank goodness. But yeah, so like, and if you at any medical center, there's always neurology residents around who know a lot about myasthenia because we teach them a lot about it. But if you're in doubt, you should call your doctor. So if you come into the emergency room, unfortunately, like the woman in the example, what could one expect? So these are things that suggest that you could be headed towards an impending crisis. You could be getting on that highway towards impending crisis. And these are things that you would notice at home potentially. So shortness of breath at rest, you're just kind of sitting in a chair and you're feeling really short of breath. Or even if you haven't been having this and suddenly like you walk down the hall or you walk up a flight of stairs and you're having some shortness of breath that you weren't previously having, that could suggest that something's going on. Certainly shortness of breath with lying on your back. So when you're lying on your back, gravity is pushing down on your chest and you're relying on your diaphragm to breathe for you. So that's often a sign that muscles are getting weak because you're trying to fight against gravity to breathe. You're trying to expand your chest against gravity. And if you're having trouble doing that, that could suggest that you're having some muscle weakness. If you're starting to use other muscles other than your diaphragm and your chest muscles to breathe, if you feel like you're using your neck a lot to breathe, these are things that we look for when we are talking to patients who are having trouble with breathing. Is your speech changing? So a lot of times breathing function tends to track with weakness in other muscles, and some of the ones that tend to go together are ones that are related to chewing and swallowing, or producing speech. If you're starting to develop slurred speech that you weren't having before, or having more trouble with chewing and swallowing, these are signs that things could be heading toward this problem. And then one thing that we look at, and there's a lot of really good papers about this that I stress to our residents when I'm teaching them about weakness and myasthenia and other muscle conditions, is difficulty picking your head up off the bed tracks very well with respiratory weakness. So just when you see a doctor and you're having trouble, it's a good idea for them to check your neck strength with you laying on your back, or if you have musk, with you laying on your front, to see if it's hard to pick your head up off the bed. And then if you're starting to have more trouble with walking or sitting independently, but it's really this top group of things. These are reasons to call your neurologist. Don't be shy. Because what you want to do is, if this stuff is happening, it'd be really nice if it was just these things and not a breathing machine. So this would be a good time to sort of intervene to try and get you on an exit from the highway towards crisis and adjust things to try and get you stronger so that you don't have to go to the hospital, or if you do end up in the hospital, that you don't need breathing support. When you come in and you see a physician, these are some of the things that you might expect us to be checking. So we'll have people take a big deep breath in and count as many numbers as you can in that one breath. And there's lots of different numbers for this. I don't ever think of this as nothing's really an absolute when you're thinking about some of the things that I have on the screen here, but some people say if you're unable to count to the number 20 in one breath, that could indicate that your breathing muscles are getting weak. I also tend to look at this sort of serially. So if somebody comes in and they can count to 30, and then we examine them again in like 2 hours and they can count to 22, that suggests that maybe this is maybe going in the wrong direction. And one of the reasons that, and then the other thing that we often look at, as I just said before, is a really good paper looking at patients who have myasthenia, who have neck flexion weakness, and it tracks very well with breathing function. And the reason I like these two things are that these are two things that I can check on every patient who comes in just right sitting at the bedside. And these are things that if I'm out of the hospital and a resident is checking, they can check this right at the bedside. It's not dependent on anybody else in the hospital. You can just check this stuff and get a sense for how people are doing and convey it to me over the phone or make decisions. Some of these other things require some special stuff. So number 3 is measuring something called the forced vital capacity, which is you have like a machine and you have a tube and you breathe into this tube as much as you can breathe in and then you blow all your air out. And we measure how much air you can get out. And there's normal values for that based on how tall you are, how much air you can sort of draw into your lungs. And we think about that in terms of percent of what we would expect for a person based on their height. But that requires a machine, and in many hospitals it requires a respiratory therapist to come. So it's not something that's fully under my ability to check at the bedside, but it's an important measurement to check. These other two things, mean inspiratory pressure is how much pressure can you generate by sucking in. So if you suck in real fast, how much pressure can you generate with that? Again, you have a machine that you do that, or a meter that you do that against. And the other is how hard can you blow out air. And there are certain values of these things that we think about that as being more risky for requiring some breathing support. But again, it's really important to monitor these things serially if somebody comes to the hospital to see, is it stable? Is it getting better? Or are those numbers starting to drop, which suggests that we need to escalate care in some way. What's not a good test for breathing muscle function in anybody who has neuromuscular conditions, including myasthenia, is a pulse oximeter. That's probably the worst test because you're going to be fooled into thinking a patient is doing really well if this is the only measure of breathing you look at. Because it doesn't take very much air to oxygenate your blood. It takes very little air to oxygenate your blood. What's happening in myasthenia is you're having trouble drawing air and exchanging air. So you're having trouble blowing off CO2 because you're having trouble getting that air out. But you're getting enough air in many cases to oxygenate the blood. So it could look like you have 90% oximetry or 100% oximetry, but you could be in big trouble. Your forced vital capacity could be like 20 or 30% of what one would expect for your height. And you could have a great oximetry. So your doctor shouldn't be relying on this. If you're in the emergency room and this is all they're looking at, you should be asking for these things. So if somebody comes in and they're having trouble with breathing because of myasthenia, what could one expect? What are some of the things that might be proposed for you as treatment? So if we go back to the patient I showed you earlier, so physician comes to the bedside, checks a lot of the things that we just talked about. The single breath count is 20. The forced vital capacity is less than half of what one would predict for her height. And the doctor and the patient are both worried that there could be an impending myasthenia crisis. And this woman was exposed to an upper respiratory infection, Z-Pak, and had recently been decreasing her immune system medicines for myasthenia. So sort of 3 big issues. And she also has a history of previous breathing trouble from myasthenia, which is another point to be concerned about this patient. So she gets urgently admitted to the hospital. And in this circumstance, there's probably one of 2 places that one would be admitted to. Either somebody would be directly admitted to an ICU-like setting, even if you're not going to need breathing support, because in an ICU you can monitor somebody. There's a 2-to-1 nurse ratio, so you have eyes on a patient at all times in case they get into trouble. Or in many places there's something called like a step-down unit, which is somewhere between a usual hospital bed and an ICU, where the nursing ratio again is a bit lower so that a nurse can sort of be monitoring people. Our step-down unit in Vermont is 4 patients to 1 nurse, and the nurse kind of has eyes on everybody at all times to make sure that nobody's getting in trouble. So this patient, she gets admitted to the ICU. There's some frequent monitoring that happens there. So a nurse might be checking your ability to count. Your nurse might be having one of the respiratory therapists in the ICU come in every few hours to check your breathing function with some of those tests I showed. And this is the point where respiratory support may be initiated. We'll talk about that in a second. This is the point where one would start medical treatments and where you might identify what might have precipitated this problem and treat it. So if somebody has an upper respiratory infection, this would be a good time to treat it if it hasn't been, but with a safe medicine. So when we're thinking about medical treatments in this setting, this is a slide that I like to show, and it's great because it keeps growing. I keep having to add stuff. So the original paper didn't have this box right here that has eculizumab and rituximab in it, so I kind of modified this chart. And I hope that this box gets bigger. So these are treatments that we have for myasthenia gravis, and on the bottom is sort of time that we would expect these medicines to be effective at improving people's strength. And you can see in the box of hours, we really have acetylcholinesterase inhibitors. So that's like your mestinon or pyridostigmine medicines, and you can add those things in. They can be useful, but in the setting of somebody who's coming in with impending crisis or crisis, they're almost never going to be enough to turn that around. But they work quickly, so they could be used in conjunction with something in that setting. And then there are medicines that work on the order of days to weeks, and this is what we're really talking about. If somebody comes in with breathing muscle weakness and impending crisis or crisis, that's where we are on this chart. And there's really only 3 things that fall into that box. There's corticosteroids, and I'll tell you what the exclamation point means in a second. And then there's plasma exchange, or in many settings they call it plasmapheresis. And then there's IVIG, which is intravenous immunoglobulin. Invariably, when patients come in crisis, the choice of treatment for the immune system is always plasma exchange or IVIG. It should never be corticosteroids in isolation, and that's what the exclamation point is. And that is because in many people, and some of you may have experienced this, for the first 5 to 7 days that you either start steroids or increase the dose of steroids, the weakness in the muscles gets worse, and then it gets better. So if you are just about to maybe need breathing support, we don't want to make you need breathing support because we gave you steroids or increased your dose without doing something else first, which is, why we kind of go to these two. Right now, rituximab, eculizumab, some of the medicines that are being proposed outside, probably not the treatment for crisis. They haven't been vetted in the setting of crisis, and we just don't know how fast they tend to work. We feel much better about these because there's a lot of experience with them. And then we'll talk a little bit about as you start to improve from crisis, you kind of get out to this side of the chart. So in the typical short term, plasma exchange, it looks a little bit like dialysis. If nobody's seen a plasma exchange machine, or you may have a family member or know somebody who has gotten dialysis, it's this machine up here in the corner. And it requires having very big IVs because you need a lot of blood flow. So there's a couple of ways that people will do it. So if you can get it, sometimes you can get a really big IV in both elbows, but it requires you to stay like in this position to do it. But many people can do this, and actually a couple of years back, the hematologists and oncologists run plasma exchange at our hospital in Vermont, And they're like, oh yeah, we do that all the time because this is the same machine that we use to extract bone marrow. So when a patient's like giving a bone marrow donation, same machine. And then there are other, so you can do those two access points. Sometimes you need to get a big catheter put in, a really big catheter put in one of the veins in your chest. That's the most common thing that happens at our hospital. And then some people need this therapy on an ongoing basis, so they might have like ports under the skin in their chest that can be used for this. Or dialysis patients sometimes have what's called a fistula, which is where you connect an artery and a vein in the forearm to generate that flow if you're going to need a lot of plasma exchange. And that's not really, if somebody's coming in the short term, that's probably not what they have unless they've been getting it regularly. And the way that this works is you sort of pull off your blood, and blood has sort of two big components. There's the fluid that bathes it, kind of like liquid, and then there are the blood cells, like your red and white blood cells. And when you do plasma exchange or plasmapheresis, what you do is you separate the fluid from the cells, and you throw away the fluid, because in the fluid is where the antibodies reside. And you get rid of that, and then you add back fluid without antibodies in it to your cells, and then you put that back into the person. So you get your own cells back. With different fluid around it. So you're kind of throwing away the bad antibodies. IVIG is also given. This is where you get pooled antibodies, which are the little proteins that are supposed to fight off infection. And by getting pooled antibodies from thousands of donors, that sort of modulates your body's own production of antibodies. It sort of decreases your own production of antibodies. And given these two treatments in the setting of a crisis or impending crisis, with plasma exchange, people typically will get 5 of those treatments over 10 days. You get 1 treatment every other day. And it's usually the 3rd or 4th treatment when people start to feel better and feel stronger. So it takes like 6 days. IVIG is a little less predictable. So we give that medicine over between 2 and 5 days, depending on what the dose is and how healthy the person is otherwise. And the effects of that could be delayed by a week. They could be delayed by 2 weeks. It's a little less predictable. But there are studies that suggest that the outcomes for these two things are pretty close, except if you have anti-MuSK myasthenia. IVIG does not work very well for that condition. So if you have anti-MuSK myasthenia and you come in crisis, you need this, not this. Many times, if you live in a rural region, this may be the only treatment that's available. You may not have access to plasma exchange depending on where you live. And like I said, steroids are always avoided initially, but then can be adjusted once somebody starts to feel better and they're out of the woods. How am I doing? Okay, doing good. So what happens next? So you come in to this woman came into the hospital. She was having breathing trouble. We brought her into the ICU. We monitored her. I guess I didn't really talk about breathing support. So the other thing that could happen in this setting is you might need some breathing support. And there's sort of 2 ways that we do that. So what you need is not oxygen. What you need is airflow. So there's sort of 2 ways to do that. So there's something called a BiPAP, which is where you get pressure with a mask. You wear a mask that sort of goes around your nose and mouth. And the machine sort of pushes air in, and it also pushes a little bit as you're breathing out. It kind of holds your airway open as you're breathing out too, and it allows you to exchange gas. And in many people, that's going to be enough to kind of get you through the acute phase, and hopefully with the medicines, we can prevent you from needing more than that. But in some people, they do need to go on a breathing tube, which is where you sort of put a tube through the mouth into the lungs, and you get hooked up to a ventilator, which breathes for you. And when you have muscle weakness, you can tell the machine when to breathe for you, and you can even give it some pressure. So it's not doing everything for you. You're doing a little bit with it, and you need that for a short term. And I'll show you what that can mean. So in this woman, she comes in, she had some assisted breathing, she gets transferred out of the ICU, and we adjust her long-term medicines. Whoops. Just kind of skip ahead. So she came out of the ICU after having some breathing support, and we adjust her medicines. And this is the point where you talk about, you know, do I need a newer medicine like eculizumab? Do I need to adjust my immunosuppressants? So that would be things like Cellcept and azathioprine and methotrexate. Does somebody need a thymectomy? Do they just need a higher dose of corticosteroids? And that's sort of outside the bounds of this talk, but that's the sort of things that we're thinking about once somebody gets out of the woods. But again, I think it's really important, and I want to close on a positive note and say that the prognosis, even though people come in with very dire weakness, is actually quite good. And it's actually quite good for most patients who have muscle problems as the result of getting admitted to the ICU. So there are people who have all different conditions of muscles. And if you need to go on a ventilator, in all neuromuscular patients, so that includes things like Guillain-Barré syndrome, which is something you might have heard about, and myasthenia, the middle time that you would need to be on a ventilator for all neuromuscular patients is 9 days. The middle time in a cohort of patients that you would need to be on a ventilator if you have myasthenia gravis is 5 days. So it's pretty good. It shouldn't be too long on a ventilator. And 5 days is about, if you were on plasma exchange, when you would expect to start to see improvement. How long would you need to stay in the ICU? So if you have any neuromuscular condition, the middle duration would be about 2 weeks. For myasthenia, it's like a week and a half. So better than the average neuromuscular patient. And again, mortality from myasthenia is pretty low these days if you get care like you should. It should be less than 5%. So in closing, so I want to leave, I got like 5 minutes for questions, is it's really important for you and your doctors to recognize the signs of an impending crisis, because we want to head it off before it becomes a problem. Crisis and impending crisis can be really scary, but they're treatable things. I always encourage people to empower themselves, look at the list of medications online, put the app on your phone, put something in your wallet, whatever works for you, and develop a good plan with your neurologists of how to treat this and what to do if things are getting worse. And don't ever be shy. I always tell my patients, don't be shy with us. If you're not doing well, call, because we can adjust things to hopefully get you feeling better. So I really appreciate you having me here, for supporting my research, and for being a wonderful organization.